In this video, we will discuss about anemia of inflammation. So first, to understand this term, many times we call this type of anemia as anemia of chronic disease. But actually, in some acute conditions like sepsis, trauma or major surgeries, the same mechanism will be happening. In these cases, we cannot term it as anemia of chronic disease because these are all acute. So the newer terminology, that is anemia of inflammation, is utilized. To understand it better, in some chronic conditions like CKD, chronic heart failure, diabetes, obesity, even autoimmune diseases, as well as in some acute conditions like sepsis, trauma, major surgery, the same pathway will be happening, that is immune activation and cytokine production, leading to anemia. We call it as anemia of inflammation. What will be the pathology? Cytokines like interleukin 6 will increase hepcidin level, restricting iron for the availability of erythropoiesis. Then interleukin 1 beta suppresses production of erythropoietin. Interferon gamma interferes with erythropoietin action on bone marrow for erythropoiesis. Also, bone marrow progenitor commitment is reprogrammed towards myeloid lineage instead of erythroid lineage, because body needs immune cells to fight during this inflammation, and there will be mild decrease in the lifespan of RBCs. These are all the pathophysiological changes happening because of inflammatory conditions. So what will be the findings in this type of anemia? There will be mild to moderate anemia. Usually it will be normocytic, normochromic, but if it is quite long standing, there might be actual iron deficiency leading to microcytic picture. And if you see, there will be low reticulocyte count and ferritin levels might be normal or even increased. This is opposite to absolute iron deficiency anemia. So what should be the treatment in these conditions? Always try to focus on the underlying cause. So whatever is the underlying reason, we have to treat that. Especially if the reason is due to some chronic illnesses like CKD and congestive heart failure and all, keep the target hemoglobin as less than 11.5 gram per deciliter. And as mentioned here, ferritin levels are quite not reliable. So the target should be about transferrin saturation, which should be maintained between 30 to 40%, and ferritin levels should be between 200 to 700 microgram per liter. And as mentioned, if it is quite long standing, there might be actual iron deficiency. So when to consider associated absolute iron deficiency in anemia of inflammation is if there is ferritin levels of less than 100. Otherwise, in general population, we take it as less than 15 to 30 to say it as iron deficiency. But in inflammatory states, if it is less than 100, take it as iron deficiency. And if the transferrin saturation is below 20%, again consider it as associated iron deficiency. So in that case, we can give IV iron supplementation. Even oral iron supplementation can be given to treat the absolute iron deficiency. Many will be in a mindset that in these acute inflammatory conditions, we should not give iron because it will be kind of a feeding factor for microbes. It is totally wrong concept. Recently, in numerous observational trials, it has been noticed that correcting the anemia, especially with IV iron supplementation in these acute inflammatory conditions ranging from pneumonia till bacteremia, it is absolutely beneficial for the patient. So do not hesitate to supplement iron if you find iron deficiency irrespective of the presence of inflammation. And regarding blood transfusion in these conditions, transfuse only if hemoglobin is less than 7 or 8 with presence of hemodynamic instability. Otherwise, no need of blood transfusion. Hope you have understood the terminology of anemia of inflammation and the pathophysiology, how will be the presentation and how to manage with the right targets of hemoglobin, transferrin saturation as well as ferritin levels. Thank you so much.